I'm Dr. Jeffrey Frank of the Norton Headache and Concussion Center. And for this talk, I'm going to be talking about what's new. Now, I have to explain something because of the COVID virus. We did not have our annual meeting this year. That's where we as headache doctors find out what's coming down the pike, what to expect. So in my talk today, I'll talk about new medications that have been approved this year. And there's a couple that I know that are coming. But as far as other medications, what else is coming up, that we're not quite sure of yet. Okay. This year, we had 3 new symptomatic treatments approved for migraine, which are the first one since the 1990s when the triptans came out. Now, you may ask, well, we have the triptans, why do we need something else? And there are several reasons. First of all, the triptans do not work for everybody. About 40% of patients who take triptans, they're not effective. There are some patients who take the triptans and have intolerable side effects like drowsiness or nausea. And then there are those older individuals who have coronary artery disease or have had strokes that cannot take the triptans. And we've not had any symptomatic, migraine-specific symptomatic treatment for them. And what's exciting about these 3 new medications is, number 1, it has a different mechanism of action. Number 2, we can give all three of the new symptomatic treatments to patients who have heart disease or stroke. So the medications, there are 2 gepants. Now I'll show you what a gepant is, but there are 2 that fit into that category. That's Ubrelvi and Nurtech ODT, or Ubrelvi and Remigipant. And then there's the third one is a ditan, which is lasmitidine, and that's Reval. And then the 4th medication that's been approved this year is the 4th monoclonal antibody, Vyetti, and I'll explain how that's a little bit different from what we have now. In my last talk, I showed this figure where this is the trigeminal nerve that releases the CGRP, and these little blue balls are CGRP. So we talked about how the triptans work by binding to this site here and preventing the release of CGRP. Because of that, the triptans have to be given early, and the earlier you give them, the better they work. Well, the gepants bind to the CGRP receptor, so really they can be given at any time in the course of the headache and still prevent the CGRP from binding to the receptor. So they can be effective even when the headache is severe. Ubrelvi was the first one approved. It's a symptomatic medication. It's taken orally. It's available as a 50 milligram and 100 milligram tablet. Once again, you can take that at any time in the course of the headache. This one you can repeat a dose after 2 hours if needed. And the nice thing about the gepants is they do not cause medication overuse. So I do have some graphs here. So this is pain relief. Now, in patients with migraines, it from moderate to severe headaches to mild or to 0 or mild headache. Okay, this is a secondary endpoint because pain freedom, which is going from moderate to severe to 0 headache, is the more stringent one that they look at. But in this one, at 1 hour, there were 43 and 36% of patients responded, and at 2 hours, 61% had pain relief. which is good because patients usually can function when the pain is mild. So at pain freedom, as you know, at 2 hours, we're only at 21%, which isn't as good as the one before. But then at 8 hours, we're up to 80% of patients. Now, a lot of the patients in the study, their headaches lasted for more than 24 hours. So having complete pain freedom by 8 hours is a significant finding. In these newer studies, they also look at the most bothersome symptom, which is either photophobia, phonophobia, or nausea. And in these patients with the Ubrelvi, at 2 hours, 38% were the most bothersome symptom had resolved. And by 8 hours, 90% of the most bothersome symptoms had resolved. Side effect profile for this medication is very low. The biggest one is nausea. With the 50 milligram tablet, there's a 2%, and the 100 milligram is 4%, whereas in the placebo, it was 2% of nausea. Somnolence is very low, 2 to 3%, and then dry mouth was very low at less than 1% for the 50 and 2%. So once again, these can be given to patients with heart problems or stroke if they're stable, and these medications do not cause medication overuse. The next one is the Nurtech ODT or Rimegepant. It's also an oral tablet, but it's an orally disintegrating tablet, so you don't really need water. This one has a longer half-life, so you only give one dose in 24 hours. And once again, it does not cause medication overuse. Now, this one is now approved for symptomatic treatment of the migraine. We'll talk a little bit about what the future of this medication could hold. Okay, so we're going to look at the same three factors. So pain freedom at 2 hours is about 21%, which was the same as Ubrelvi, and at 8 hours is about 56%. Pain relief at 2 hours was 59%, and at 8 hours was 74%. And then this one looked at the ability to function normally at 2 hours was 38%, and at 8 hours was 65%. The most common adverse reaction of this one was nausea, and again, it's very low at 2%, so very well tolerated. The third symptomatic treatment that was approved is Reval. Now, this is an oral medication available as a 50 milligram, 100 milligram, or 200 milligram, usually one dose within 24 hours. This is a controlled substance, and unlike the other two, this one can cause medication overuse. So for the same three categories, pain freedom was 28 to 39% at 2 hours. Pain relief was 56 to 61% at 2 hours. And relief for the most bothersome symptom was 41 to 49% at 2 hours. So fairly good numbers. One of the problems with Reval, it has common side effects such as dizziness, drowsiness, and tingling. And it's cautioned that you are not to operate, you're not to drive or operate dangerous equipment for 8 hours after taking the Reval. So it's a little bit disheartening in patients where you want to get them back to functioning normally. They're not going to be able to do that with the Reval, but if nothing else is helping, at least they can be disabled without the headache. So Vyetti is the fourth monoclonal antibody that was approved, and this one's different because it's given as an IV infusion every 3 months. This is a prophylactic medication. It's not given for preventative. And it's given as either 100 milligram or 300 milligram. In the studies, over 30% of patients achieved a greater than 75% reduction in migraine days in both the episodic and chronic migraine trials at 1 month. And then there was a consistent 50% reduction in migraine days for both episodic and chronic trials at every 4-week interval for 6 months. Adverse reactions, greater than 2% was nasopharyngitis, and that's it. Hypersensitivity occurred in 1% of the 100 milligram patients and in 2% of the 300 milligram patients. So there are 3 brand new symptomatic treatments, the first since the triptans were introduced since the 1990s, and 1 new prophylactic medication. It's the only one that's given IV form. Now, as far as what's coming down the pike, there is another one of the Gepants, which is a longer acting one, atogepant, that will be hopefully approved for prophylactic treatment. And then there are studies on rimegepant, which is the Nurtech ODT, also for prophylaxis. And we're hoping in the next months to years that will be approved for prophylactic treatment also. So this is just a short talk, once again, because our annual meeting was not held. We don't know a lot of the brand new things that they're looking at for migraine. Hopefully next year we'll be able to have our meeting, and I'll be able to talk about much more in what's coming down the pike. Thank you for your attention.